See.
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this time with us, and we hope that you will get something out of the conversation that we're going to have today. I'm really looking forward to it. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, and thank you, Dr. Barbara Davis Stevens. Hello, my favorite purveyor of Thorazine for me, Dr. Wilkes, and also Dr. Hines. I want to give a special welcome to our guest speaker who got up in the middle of the night, even though he's in the Middle East. I don't know what he's doing, catching bombs or whatever, but we thank you for being so loyal to us to get up in the middle of the night and talk to us. And we're going to talk about something that has been a crisis over recent years, and that's the drug called fentanyl. And I was surprised when Dr. Stevens sent me the fact that fentanyl has been put in lollipops as a painkiller. But I'm going to let Dr. Chapman, who's one of the country's renowned internal medicine specialists he limits his practice to the drug treatment of type 3 and 2 scheduled drugs, especially the heroines and the morphines and the other things in fentanyl. And he's testified a number of times in front of Congress, it seems almost every week. And we certainly welcome you and thank you for coming with us, Dr. Chapman. The floor is yours.
Well, first of all, Dr. Maxey, I'd like to congratulate you on being recognized as Practitioner of the Year for the National Medical Association 2024. I didn't have an opportunity to see you during the convention, but I certainly want to take this opportunity to make that statement. But again, the opioid epidemic has been with us over 20 years. And as you know, initially, it was not even recognized as a problem in the African American community, even though we know that we've had an opioid problem for over 60 or 70 years. So that about 25 years ago, opioids were being really utilized as a relief for pain. We started scoring pain as the so-called fifth vital sign, and the fact that if you were not adequately treating pain, that you were really not practicing good medicine. So there was a dramatic push from some of the manufacturers of opioid products, and then an increase in the potency of opioid products, even though these manufacturers knew that patients were becoming addicted. So we really didn't actually see fentanyl in our drug supply because that was generally a pain relief used in hospitals for patients post-op and for patients with cancer. But we didn't really see fentanyl in this epidemic until around 2014, 2015. And suddenly we started seeing what I thought initially was a contaminant. So I first recognized it in Washington, D.C. in 2015. And we had a 20% uh, poisoning with fentanyl, which was not hospital-based fentanyl. These were fentanyl analogs that were being distributed and mixed in with the street drug supply or heroin. So this was not typically coming from doctors or hospitals. This was coming from a purposeful infiltration of our drug supply. And again, in Washington, we recognized that and brought it to the attention of the government through the work that we were doing, Dr. Lawson and I were doing with Howard University College of Medicine as the chair of psychiatry, and also the Howard University College of Pharmacy. So we jumped from 20% fentanyl in Washington to 62% in 2016. And then it continued to go up. And we started seeing even more analogs of fentanyl, which means that they were being synthesized by street dealers. By 2019, our drug supply had 91% fentanyl. And the last documents in 2023, we were up to 96 to 98% fentanyl. So our overdoses were not coming from our doctors overprescribing. They were coming from these street analogs. So our African American overdose episode was very, very different from the white epidemic. And just recently, or just the other day, for the first time, we've had a 10% decrease in overdoses in the United States. That's unprecedented in this epidemic. And nobody really knows why. We're not really sure what has happened that has created this. So I can only speak right now from our experience here in Washington. We've in fact, since January, had a 30% decrease, I'm sorry, in overdoses. And when you look at the data from the chief medical examiner here in Washington, we still have 96 to 98% fentanyl. We did note an increase in xylazine, which is an animal tranquilizer that was first recognized, I believe, last year here in Washington, but it's been recognized in places like Philadelphia and really in 98% of the states now are seeing xylazine in addition to fentanyl. So xylazine it actually stretches the high. It makes it last longer. So there's some theories that perhaps, and even though xylazine causes terrible skin ulcers if it's injected, there is one of the theories is that the fact that it stretches the high, that perhaps people are using less often, and therefore maybe that has an impact on the decrease that we're seeing in overdoses. But we really don't know at this point why we're seeing this decrease, and that's going to be something that we really need to sort out on a racial, ethnic, and geographic basis across the country.
One of the questions I have based on what you were saying, Dr. Chapman, is there a difference in the way that African Americans use and get overdosed by fentanyl and the Caucasian Americans? Is there a difference in that pattern again? I think you mentioned something like that.
Yeah, so we've seen two patterns evolve over the past 5 or 6 years. One, there's been a dramatic decrease in prescriptions from doctors and hospitals. And of course, because of all of the above, the way our epidemics differ, you would expect to see a decrease in overdoses among Caucasians and rural and suburban areas. So that's one factor. In our community, because we can't do anything as professionals to change what drug dealers do on the street, that would have very little impact on our patient population. The other thing that we've noticed is that instead of injection drug use, people are now overdosing at a higher rate, according to the CDC, by smoking. Again, these are polydrugs for the most part. So if you add fentanyl to marijuana, fentanyl and cocaine, fentanyl and amphetamines, and smoke it, then you're not typically going to see the ulcers that I described with xylazine. But you can actually smoke fentanyl and overdose. So to be more specific, in my practice, I have 50 patients who have tested positive for fentanyl and xylazine at the same time. And none of those patients have presented with non-healing skin ulcers. So my suspicion is that most of our patients are now smoking it.
Before I ask Dr. Neighbor Stevens to join the comments, I read a story recently about two workmen who were cleaning up an apartment, and apparently there was something on the floor in the closet, and just by touching it, they died. Transcutaneous.
So again, that's been one of the issues that's been discussed a lot. I think most experts have refuted that as a cause of overdose. But that's always, there was a period when if somebody overdosed with fentanyl, the police in some places had hazmat suits, et cetera. But I think most of those stories have been disproven in some way.
Okay. Dr. Barbara Neighbor Stevens.
Thank you. Dr. Chapman, what got me started on this path this week was I saw the article that I sent to you that was discussing how the FDA has convinced the manufacturers of the fentanyl lollipops to stop manufacturing them. And the question I had was, I mean, I get that any fentanyl that you can control is fentanyl that you want to control, but the amount of use of these lollipops, I won't say it's infinitesimal, but it certainly is a very small. In fact, the article said there were only 150 patients with prescriptions for them. So I didn't see how this was really making a big difference on the epidemic that we are trying to get control over. So that was why I raised the question, what's the big deal about the lollipops in terms of controlling the epidemic, and what now do we need to put our attention to in terms of trying to control the epidemic?
So you're absolutely right. If you think back, many states instituted PDMPs, pharmacy reporting of opioids. So anytime that you write a prescription for an opioid for a patient, you had to check the PDMP to make sure that this patient was not getting opioids from another source. And just as you pointed out, the PDMPs had no impact on the African American opioid epidemic because ours was a heroin to fentanyl, a street fentanyl epidemic, not a pill epidemic from physicians. So another analogy would be the simultaneous use of benzodiazepines. There were only a handful of cases of benzodiazepines and fentanyl overdoses in Europe. And those were cases, not fentanyl, I'm sorry, but like buprenorphine and benzodiazepine overdoses in Europe, and that was because the people were actually injecting buprenorphine, which is one of the three drugs used to treat opioid use disorder. So some of these interventions that the government makes are done without first looking at the science behind it and whether or not it really makes sense. So I haven't seen the article that you referenced, but again, if you think about all the prescriptions for opioid pain relief and who they're generally written for, that I would really want to look at the details, because again, usually fentanyl is written for post-op patients or patients who have cancer.
Dr. Waltz.
Thank you, Dr. Maxey. Good afternoon, Dr. Chapman, and thanks again for being with us. I know that with your tremendous expertise and your commitment to being available to this to speak on this topic, sometimes we have to play the game. Where in the world is Dr. Chapman? But wherever you are, you make yourself available, and that's a wonderful thing. Because we have a lot of our audience is a lay audience, I just wanted to ask you to go back a little bit and talk about the connection with fentanyl and with opiates in general. You talked about how the fentanyl in the African American community is more of a street combination and folks are smoking it. But I wanted to ask you to go back a little bit and to let people know exactly what fentanyl is and why people are combining it with drugs. Like you buy marijuana to smoke it and you wind up getting some fentanyl in your marijuana, or you get fentanyl in other things, and why people are putting it with other things, and what does it do when you combine it with other things.
And can you add to that about the relative potency of fentanyl versus heroin?
So we're again not talking about pharmaceutical fentanyl generally, which comes in patches for pain relief. It can also come in pill form, and as Dr. Stevens mentioned, these lollipops that again are a convenient way for delivering this medication. But generally, the street fentanyl that we're talking about is 50 to 100 times more potent than morphine. And so we're talking about an altogether, it's an opiate. But again, it's a synthetic opiate that is manufactured. And I see we have Dr. Lawson on, who we just talked about this several days ago at our with Dr. Lawson as a featured speaker at our local MedChi meeting, which is the local chapter of the National Medical Association. And he always tells us that why do people take drugs? Either to feel good or to feel better. And of course, for pain relief as well. So we have this conundrum about really what underlies why anybody takes a drug that's not prescribed to them. So we have to think about people who are suffering from mental health problems, and generally we're talking about anxiety and depression, not that the person is suffering from paranoia, schizophrenia, or anything like that. People just want to feel better, and people just want to feel good. So when we put that in the context of our community and the stressors that we see every day in our community, from economics, from the psychological stress I tell people all the time, just turning the TV on and seeing certain politicians is cause for anxiety and depression, post-traumatic stress disorder that we've been going through for the past, for 400 years. So we can't really separate our unique history in this country from everyone else. And I think that's why, again, our epidemic was primarily the use of street drugs as opposed to medications from the doctor's office. And I think that's a very important point, the fact that our physicians have been very careful. And in fact, our patients have often been discriminated against when it comes to pain relief. Our patients are not prescribed these powerful medications because of racism and the fact that there was always this concept of potential diversion of these medications. And the same thing applies for treatment with methadone and buprenorphine. Two of the three FDA-approved medications are far more difficult to get in our patient population for treatment because, again, it's always felt that our patients are going to take this medicine and divert it or sell it on the street and not take it for treatment of themselves. So we really, this is so important that we have these discussions because our community is often lumped into the other communities, the larger community, and we end up with regulations or guidelines that really don't apply to our population.
Yeah. While we look at the chat to see if there are any questions, I'm going to ask Dr. Lawson to make a comment since he was referenced by Dr. Chapman.
Yes, Dr. Lawson.
If we can unmute Dr. Lawson.
He's the one who won't invite me to eat barbecue at his house. Is that right?
And he has some important people at his barbecues too, believe me.
Okay,
So-
I'm gonna come and
so-
see.
Got it.
So
Thank
there we
you
go.
very much. And I think Dr. Chapman hit the key points. Well, I just want to just reemphasize several points. One is that these drugs are so in terms of pain relief. So why do people take them? Because they're not just getting relief from pain, they also cause euphoria. It makes you feel good, at least temporarily. Secondly, there's good research, and I was involved in one of the studies showing that the opiates have antipsychotic properties and have antidepressant properties. And there have been attempts to get some of these agents approved as antidepressants. And it's usually failed. Why? Because people go out, a large percent, not everybody, but a large percent of the population will go out and get addicted. So these are drugs that have true anti-anxiety, antidepressant, antipsychotic properties, but it has to be balanced against the fact that you can be addicted. And then there's also, we must not forget the economic factor. So anyone knows when you go out and get health care these days, the Affordable Care Act helps some, but many pain relievers, many treatments are expensive. And they also, an effort to prevent people from becoming abusers, they have limited, you can only take many of the prescribed medications for limited periods of time. So people go to get the street drugs, which was good. The good marketing folks in the community already discovered. You lower the price, and you can get the person that was using some opiates for pain relief now, but can't get them anymore because of cost, as I said, because the fear by many providers. You got Black folks using these drugs. They're going to become addicted and steal from people and create crimes. And so they had to turn to the street to get relief, for legitimate relief for pain. And then most importantly, there simply aren't many approved drugs that can produce anti-anxiety, antidepressant feelings but not only that, then make you feel good, get a little euphoria at the same time. So all of these factors are coming together. Age, where you got age-related pain, cost, the economics of how you're going to get pain reliefs, feeling good, so you don't have to you get a cheap high without having to go to the movies or having a good time. And also the fact of the matter is that most importantly, they do give people what they call a cheap thrill. And also they are available. You don't have to go to a prescriber. Many folks get the word out, go to the right place in the street. You can get them right on the street corner. So there's a lot of factors in our society that's reinforcing this. And I just saw an interesting article in the Post showing that despite the efforts to restrict oxycodone and other drugs, the companies that made it is now making big bucks over the seas. Where the U.S. has restricted the use of some of these drugs, but the rest of the world has not been. And so there's a huge opiate crisis that is emerging in other countries.
Well, thank you. Dr. Walker, anything in the chat?
Nothing that I see in the chat. I wanted to just follow up on one of the things that Dr. Chapman and Dr. Lawson both mentioned. When we talk about availability and street drugs, and we talk about pills, there was an earlier part of the conversation about the folks who touched the who reportedly touched the fentanyl and were impacted by it. And though that may not be the way that folks ingest or get fentanyl into their body, you can swallow it, you can inhale it. And so when it's just sort of around, there is a risk of especially younger people putting things in their mouth, touching things and putting things in their mouth. And you mentioned earlier, Dr. Maxey, that it doesn't take a lot of this to really cause a big problem. And I wanted to see if Dr. Chapman, you could talk to us a little bit about just how little fentanyl it takes for you to get in a really big problem with an overdose of fentanyl.
Yes, so there's actually a court case that was reported in the Washington Post of a mother who was using fentanyl and fell asleep with a 3-year-old, I believe, on on the bed. And when she woke up, that 3-year-old had ingested some of the medication. Now, it sounds like in this particular case, they were actually fentanyl pills. And when she woke up, the child was in respiratory arrest and subsequently died. So that case is actually being tried. I don't know the outcomes of that case, but again, there are cases where people have, and particularly when you have a person who, let's say, uses cocaine and or amphetamines, or even drugs like from the internet that they think may be OxyContin that's actually been spiked with fentanyl. So there are a number of overdose cases due to people who are really not trying to use opioids. They think they're using something else, and the drugs that they use have been spiked. So that's we know that that's happened a number of times. The exact percentage, I'm not sure, but it is a problem.
Dr. Chapman, let me ask you this, and we've heard so much of the political rhetoric in our country talk about fentanyl coming across the southern border and the northern border. Can you comment on how fentanyl affects our community and how it's mostly trafficked, to your knowledge?
Yeah, so again, that's a political ploy because these precursor ingredients can be mailed into the country and then assembled here in the United States. So, and that's happened in Arizona. They've had major fentanyl mills in Canada. So we talk about the southern border, but that's just a political ploy at this point. These drugs are so easy to import, and the precursor ingredients, and then assemble here in the country that we know that this is just, these are just politicians who are trying to undermine common sense that these drugs can come in from any port, and you see places like New Jersey, Baltimore as ports of entry that are very difficult to control. And in many instances, they say even those who are transporting them across the southern border are actually American citizens, not people who are illegal immigrants, so to speak, who are coming across the border.
So one more question on that item. Can it be manufactured in the United States without importing anything?
Not to my knowledge. For the most part, they say that the precursor ingredients come from China, and they either go to Canada or Mexico. But these precursor ingredients primarily come from China. There have been interventions that at the highest level where the president has talked to the president of China to get these illegal manufacturers to cut back, but how effective that is anyone's guess.
So we don't have fentanyl in New Hampshire, do we?
You have fentanyl everywhere.
I was picking on somebody.
Dr. Maxey, Dr. Lawson has his hand up, and when he finishes his comment, I have a question for Dr. Chapman.
Yeah, I just want to emphasize a point that Dr. Chapman used to make, but a lot of the people who listen to the show probably just dismisses it because it doesn't seem like it's related to anything that they're involved in. I just want to emphasize this point that on the street is used to adulterate other products. It's not called that, and most importantly, if it kills you, you don't feel bad before it happens. It's a very potent respiratory depressant, and a lot of folks will go and say, the guy offered him something, let me try this out. I don't feel bad, and the next thing they're dead. And Dr. Tappan can tell you some examples of folks literally overdosed in his waiting area. And the important thing is that we need to help the community become aware. Don't feel bad. You're not sick. It's not some guy standing on the corner and say, hey, try fentanyl that's available. It comes in very benign looking situations. And that's why the death rate is so high. And it's also tied in with physician distrust. Our community don't trust our physicians and are much more likely to listen to their buddy and say, try this out for your pain or to feel good than they are to listen to their providers.
So it might be in the Viagra you get over the internet, correct?
Exactly.
I'm serious. Okay, Dr. Neighbor Stevens.
Dr. Chapman, could you comment on the demographics of the fentanyl and other opioid epidemic in our community, with the follow-up question to come, how can we prevent our young people? In the past, we've done this heavy-duty smoking is bad for you, and it did impact tobacco smoking activity in the young adult. But if you would tell us about the demographics and what we can do to try to prevent our especially our young people from getting caught up in this?
So again, our epidemic in the African American community has been primarily a conversion from street drugs, heroin to fentanyl, and we did see an up spike beginning maybe 4 or 5 years ago in young people here in Washington who overdosed, but for the most part, it seems that these were inadvertent in many instances from people going to a party and they would take a pile of pills, benzodiazepines, opiates, etc., and and people would just pick what they wanted, and there were overdoses related to that. You heard about overdoses related to people buying or young people buying drugs off of the internet, as I mentioned. But a strange thing has happened since January here. Now we had 12 overdoses in young people between the ages of 16 and 19 in 2023. As of this year, through May, we've had zero overdoses in the District of Columbia. So again, we don't know whether it's messaging that now the young people are listening, or what has created this dramatic decrease here in the district. But hopefully, these messages are getting out in the schools and on the internet and by education, and perhaps there's not. I just think that it's going to be a matter of education. You know, that we're really going to have to find ways to keep young people occupied with positive activities, but education is going to be the key in terms of what's out there, and the potency, and the fact that these are poisons, and I don't know any other way to state it. You know, education is the key.
Thank you.
Thank you so much. Thank you so much. Anything in the chat we need to address, as neighbor?
No, Dr. Steiner just said he was on mute, and yes, it is in New Hampshire.
Okay, I just like to mess with Dr. Snyder up there in the beautiful New Hampshire forest out in the country. We're almost at the top of the hour, but I just want to bring up one quick subject that Dr. may want to chip in on. That we know that the epidemic of COVID is back with us, if it ever left, but people are getting sick in record numbers, and we know there's a new vaccine available as of the 24th of this month, I think. And I'd like just to briefly comment on that before we ask our speaker and co-moderators for last words. Any thoughts, Dr. Neighbor, Dr. Walks, Dr. Lawson, Dr. Chapman?
I'd like to let me start with a thought on that, Dr. Maxey. I was at church this morning and I had on my mask, and one of the folks at church came up to me and said, "Oh, I know that you keep up with all the trends." And I thought that he was going to talk to me about my wonderful suit I was wearing, but that was not the case. He was talking about the mask. He said, "I don't always see you wearing a mask. So I see you wearing a mask today." I said, "Yes, I'm wearing my mask because the COVID numbers are up. It's cold season, it's flu season. There are a lot of things going on. And by the way, we do have a box over here of masks. You can feel free to take one," because I was ushering this morning. I was at the door. And I think that sometimes the best way to do things is to lead by example. What we get with Dr. Chapman and with Dr. Lawson is a lot of education and information for folks, and we get folks who are willing to lead by example. And so I'm just trying to be like them. I'm trying to go out acting like I know what I'm supposed to do, and then doing what I know I'm supposed to do. And we are in a period where if you're going to go out, you're going to be around a lot of people. It's a good idea to wear your mask, pay attention to how you're feeling. Get some COVID tests. If you don't feel good, take a COVID test because there is treatment in consultation with your doctor if you do test positive. So I'll leave it at that.
Thank you. And Dr. Neighbor, I know you have a comment as a pediatrician, but would you also speak to those of us who are a bit over 60 in terms of people exposing us who are not vaccinated? Last words.
I'm sorry, Dr. Neighbor Stevens, did he say a bit over 60? Is that what he said?
That is what he said.
I'm a genuine senior citizen.
Well, things haven't changed from when we started down this path. So, not only can you rely on common sense, but you can rely on history. And we know that if you have reason to have a weakened immune system, whether that be from conditions that you have, medications that you're on, or you've been blessed with years beyond 65. All of these are ways in which your body's mechanisms for fighting infections may not work as well as they could. And that is why vaccines are a good idea in the first place. I just wanted to make another editorial comment, I guess, on the vaccine availability and what's going on. We have been very well educated over the last 3 years about the nature of the COVID virus. And we know, because we were taught, that it's going to mutate, and it has mutated several times. And there is a new strain that has been monitored in Europe, specifically Germany, that is now beginning to show up in the United States. And it is thought that it is going to be the next predominant strain. But so what? The vaccine is here. Go take it.
Thank you, Doctor. Dr. Chapman, we thank you so much for giving up your time, especially over there in Dubai. Love to have some final words for you and welcome to speak not only on the topic that you brought to the table, but also on your thoughts about what you think about COVID and what people should do. Both Dr. Stevens' patients, the young ones, and Dr. Walsh's patients, the old ones, like me.
So I think it's really poignant that you've linked the COVID epidemic to the opioid epidemic. And what's the common denominator? The common denominator in my mind is the fact that in our country, we do not have national health insurance. The Commonwealth Fund just published a report that showed that in the 10 top industrialized countries, the United States comes in last. And who's number one? Australia. And what kind of healthcare system does Australia have? They have national health insurance. So when we put all of this together, when we talk about the COVID vaccinations now costing $200 and the government not paying for it, or if you don't have insurance, you're probably unlikely to get it. And then on the opioid side, Narcan was distributed free in most places. Now it's over the counter at $50 a whop. And if you don't have health insurance, you can't get treatment for opioid use disorder. So I think we really need to move our discussion into the future and what kind of healthcare system are we going to have? And we've learned a lot of good things and bad things from this epidemic, and the fact that we need to take a village approach. When you don't get a COVID shot, you're not just doing something to yourself, you're also doing it to your neighbor. Because if you get COVID, then you're more likely to pass it on. So this village approach, and this is something that Dr. Lawson and I have worked on for over 10 years, really reintegrating mental health substance abuse and primary care. We can't separate the head from the body. So we really have to change our healthcare system and really pattern ourselves after the systems that work best in the world, and not follow a lot of politics. So I think under hopefully a Harris-Walsh administration, that our focus should be on national health insurance. Everybody needs health care, and health care is a right, not a privilege.
Thank you
Amen.
very much. Dr. Lawson, I want to take a shot at that last question about the vaccines and older people who have conditions.
If we can get Dr. Lawson unmuted, that would be great.
Yeah, I just want to make a point again, what Dr. Chapman has noted, and look at it, we're facing formidable odds. I just since was watching one of our top networks saying that you should not trust your physician. Also, and also, I'm also dealing with a effort by there's a certain politician who's actually had an anti-vaxxer join their campaign. So when there's massive money to maintain the status quo, this program is one of many, but the question is this going to have an impact against a larger forces that is, one, keeping the status quo what it is, two, limiting health care to those who have many resources, and three, keep it out of good health care out of the concept of African Americans. I was glad to hear that Dr. Walks out at his church, being an usher. The church should be in the forefront in promoting positive health care. Our barbershops should be in the forefront. Our beauty parlors. Folks don't want to listen to their doctors. Listen to those indigenous activities in our community that can really make an impact, that folks really listen to.
So thank you so much.
Amen.
So
Amen.
Dr. Walks and Dr. Barbara Neighbor-Stevens, let's make sure last comments.
Dr. Maxey, it's always hard for me to make short comments.
I know
I'm
that.
happy to
That's why I
make
said it.
medium and longer comments. No, I wanted to go back to something that Dr. Chapman really focused on and Dr. Lawson also amplified. Why is it that people are taking these drugs, these street drugs on our streets in our communities? And a lot of it has to do with this euphoria. What does that mean? It means that folks are trying to feel good. And I think that the more we can engage with each other, the more we can get our young people to be involved in positive activities. It is really hard to shoot a good jump shot in basketball if you're feeling euphoric. It's really hard to kick a soccer ball accurately if you're feeling euphoric. There has to be a certain amount of connection to your environment and interest in your activity and doing something if you're going to do anything accurately. I've several times walked down the streets in Washington, D.C. and other places and seen folks doing something called nodding, where they're just kind of sitting there and they're doing this. And before you say something, Dr. Maxey, this is not in church. People nod other places, but they're sitting down nodding. And it's usually when someone is just completely detached from where they are. They are in some sort of a euphoric state. And so I think us being willing to acknowledge that people are part of our community, even if they're not dressed well, even if they don't smell good, and trying to find ways that we as a community can engage with each other, give folks something else to do, and then partner with the organizations like Dr. Chapman's and the work that he's mentioned with Dr. Lawson, and put resources into those efforts to treat people from this addiction that has been caused by these drugs. If we can do a lot of those things, we can have a healthier community. And though here on the Black Health Trust, no matter what you try to do, Dr. Maxey, we cannot endorse any particular political candidate. We can encourage folks to understand what the different candidates stand for. We can encourage folks to actually use the vote that people have died so we can have, and use their power and that power in the vote so that we can elect people who have the same interests that we have.
Thank you,
Thank you.
Doctor, for that very short comment. Dr. Barbara Neighbor Stevens.
Well, I want to encourage everyone, as I'm sure our audience is doing this anyway, but I really want to encourage everyone to be aware and educate yourselves as best you can about what's going on. I consider myself fairly up to date on what's going on. At least I thought I was until today. I heard this report on some of the voter repression activities that are going on, and the fact that the requirements that are being attempted to be put in place requiring not only your birth certificate, but your marriage license if you are a woman and have a name change, or an official document showing that you have a legal name change. This is something that has not been discussed, and the results that, and I don't think they're unintended, but in this conversation, because of this requirement of birth certificate and marriage certificate, which most people don't have, there is the potential. What got my attention was that there is a potential of disenfranchising 90% of the women in this country. Now, I have done the research. I cannot verify this. It was a conversation on a reputable national news, but just because it's on the national news, you can't assume it's true. But even if it's not 90%, how many people have right now can go to somewhere and pull out their birth certificate and their marriage certificate? So there is an all-out effort in play to disenfranchise as many people in this country as possible. And I just want to encourage everyone during these very troubling times, stay on top of it.
Thank you, Dr. Neighbor. As my last comment, I want to bring to the attention of people that in our community, the Black and brown community, we house and take care of multi-generational relatives. We have great grandmas, grandmas, elders like myself. And not only do you need to protect yourself from COVID and other infections, that's one thing, but you need to be able to take care of and respect the people who are at more risk than you are by protecting them, by wearing masks, by taking your vaccines, and understand that not only do you have to protect yourself, but you have to protect the other people that you love. Thank you and good day for everybody. Have a great day. And Dr. Chapman, thank you for calling in from Dubai. I'll fly over and meet you anytime you want. Have a great day and thank you, Simon.
Bye,
Good day,
everybody.
everyone.
Bye-bye.